Good morning. I'm Professor Carmelle Peisah from Sydney, Australia. I'm an old age and human rights psychiatrist. I'm a conjoint professor at the University of New South Wales, Sydney, and founder and president of human rights charity Capacity Australia. I'm delighted to be able to share with you a topic about which I'm so passionate today, but in particular to be able to share some of my resources. In particular, if you go on our website, Capacity Australia, we have a number of resources, but in addition to that, our free text is widely used around the world to address a number of capacity and human rights related issues. So what are we going to do today? I'm going to talk about the current human rights frameworks and the current advocacy for older persons' human rights. I'm going to talk about the basic principles of capacity assessment and how clinicians can support the human rights of older persons in their everyday practice. So let's talk about some of the current human rights frameworks and the current advocacy for older persons' human rights. What rights frameworks are we talking about? Well, of course, there was the Universal Declaration of Human Rights in 1947, and that was followed by international covenants on economic, social, cultural rights, political and civil rights. Then there was the UN Principles for Older Persons, where older persons got a look in, first got a look in anyway, in 1991, and the most recent Madrid International Plan of Action on Ageing in 2002. The one that we perhaps most reference in older people's mental health is the UN Convention on the Rights of People with Disability in 2007, the CRPD. This is a map of the state parties to the CRPD, and I'm sure that anyone participating in this webinar, their country would be a state party to such. Of 50 articles, the most salient for us working in mental health, and certainly ones that I reference almost on a daily basis in my clinical work, is the generic Article 12, which talks about equal recognition before the law, equal legal capacity, and the absolute right to get support in decision-making. The need to talk about expression of will and preferences. So in clinical notes, I will often refer to a person's will and preferences, referencing human rights, and the need to safeguard against undue influence and abuse. Article 14 is ever more salient in the context of the COVID-19 pandemic in regards to the liberty and security of the person, particularly people in residential care. Article 16 expands on what's talked about in Article 12 to be safeguarded against undue influence and abuse. Article 19, again, very salient in the face of COVID pandemic and older people being congregated or segregated, living independently and being included in the community and not shut away. Article 22, respect for privacy, and certainly relevant in much of our discourse about sexuality in older people. Article 23, respect for home, the family relationships, again, relevant in the COVID pandemic. Finally, Article 25, the enjoyment of the highest attainable standard of health without discrimination, including respecting specific needs arising on account of disability. So often, when we see the word disability in this context, in our context, we're thinking of mental health disorders and cognitive impairment or dementia. This is all very well, but the existing human rights landscape is pockmarked with craters of violations. There's an invisibility of older persons in human rights systems. The aforementioned CRPD doesn't specifically refer to older people. I've just extrapolated that and relate it to my everyday work. If you look up, if you try and find age in some of those treaties that I talked about in the previous slides, this is what you get up with. This is what comes. Prohibits discrimination solely on the ground of race, colour, sex, language, religion or social origin. No mention of age. Where they are referenced, and I'll show you where they are, it's often not a non-binding and unenforceable framework. And there certainly is an implementation gap between these aspirations, the articulation of these human rights values, principles, and the actual enjoyment of such. And I don't think we walk the talk. There's a lot of talk. This has led to the UN Open-End Working Group's debate about developing a specific treaty talking about the rights of older people, and perhaps a more normative one that isn't necessarily based only on disability. I've added some references here that you might find very helpful. The most neglected human right is ageism, except in the Madrid International Plan of Action on Ageing, which is not binding and is not particularly enforceable. It's not a human rights treaty, but it does talk about building a society for all ages and avoiding ageism. And our own Liat Ayalon, and when I say our own, often does beautiful papers for international psychogeriatrics like this one, talks about that human rights shouldn't be differentially allocated based on chronological age. I think if you Google Liat Ayalon, a world of resources comes up, and you'll see me mention her a lot. And I think that's useful because this is what I'm talking about, spreading the word and also finding where there are really useful references. So what is ageism? It's psychological distancing based on aging anxiety, a them versus us attitude. Interestingly, only yesterday I heard of an older person's retirement village where they were precluding the body corporate within this retirement village of older people were precluding ramps and disabled amenities because they didn't want to be associated with old people who were disabled. So even older people, that's a type of internalized or self-ageism, but this very much psychological distancing based on the fear of what will happen if I'm like them, and its exclusion of older people. And this categorical distinction of being old, I frequently repudiate. Yesterday, I gave a lecture to medical students on positive ageing and avoiding ageism, and at the same time to a large community group, and talked about at age 57, I consider myself aging, older. There is no concept of old. In fact, the only definition for me is anyone who's proud enough to say they're aging or older. This paper by Chang, it's a systematic review in health, is perhaps the most cited paper right now, and it certainly shows that it's rife across 45 countries over 25 years. It isn't getting any better. And what surprised me, that it was more prevalent in less developed countries. And I think that's something we need to look at. It's very clear in the interface between disability and ageism that society needs to make equal adaptations for people, older people with impairment, the same that they would do for younger people with impairment, to not provide living conditions that are suitable and meet the needs of older people with disability as per Article 25 of the CRPD is ageist. How does all this link together? Ageism, healthcare, and human rights. Certainly with self-ageism comes a whole bunch of negative assumptions, a sense of nihilism, low expectations of the quality of life, and indeed perhaps self-neglect. That, added together with clinical ageism, as demonstrated in Chang's paper, the apathy, the not trying, the giving up, the therapeutic nihilism that's often seen amongst our colleagues, leads to poor care, inequitable care, and an abrogation of human rights. Particularly self-ageism compounds multiple jeopardies. It is associated with more severe psychopathology, depression, underutilisation of mental health treatment compliance issues, and participation in positive lifestyle, healthy lifestyle, diet and exercise. What's the point if you're old, self-ageist, to do anything to make yourself healthier if it's all pessimism. And it's certainly alive and well in mental health, this therapeutic nihilism. Now, this shows you my obsession with Liat Ayalon. I make no apologies. This chapter comes from this book, which is available online from Liat's website. What amazed me, if you look at the list of chapters in this textbook, it shows the widespread manifestations of ageism in the labour market, in healthcare and long-term care, the Council of Europe, legal system, neuropsychological tests and ageism specifically in dementia, ageism in mental health assessment, the previous slide I showed you, ageism in medication use. It just goes on and on. And we know in COVID it's rife. This is another paper from Ayalon et al. In the Journals of Gerontology from this year, which actually did a review of some of the media reports of older people. And the ageist manifestations of such. I invite you to join with me in my battle. Attending this course means automatic compulsory enlistment against our ageist enemies. He's not just coming to Australia, coming south, he's coming to you, and he's there right now. Now let's move to the other big topic today, is understanding the basic principles of capacity assessment. And you can see the interface. This is what I talk about, the 10 commandments, the general principles for capacity assessment. Number one, what is capacity? It's the ability to make decisions, often thought to be synonymous with the concept of competence. Without a doubt, capacity is a human rights issue and is very clearly articulated in the Convention of the Rights of People with Disabilities, Article 12, as you saw in one of the previous slides. Very important that people are free of undue influence and abuse and the equal right to health. An understanding of capacity will allow you to address these issues, these human rights issues. And I very much feel that mental health care professionals act like filters in the way that they allow people who are capable of making decisions or who are not given the support that they needed to make decisions, and at the same time prevent the people who cannot make decisions, and in doing so make decisions that actually contribute to abuse or undue influence. They prevent them, so they're acting like a filter, allowing the right people to get through in terms of decision making. That's how you can make a difference. Capacity is decision and task specific, and it cannot be extrapolated. Mrs. X has dementia and she's unable to make decisions. To have that global rejection of decision making is an abrogation of human rights. Number 4, capacity can vary within tasks depending on complexity. So a person might be under guardianship, they might be under administration, they can still vote, they can still marry, they can still perhaps, they can still make certain decisions about healthcare even though they might be under guardianship. It depends on the complexity of the decision. A lot of these issues are expanded upon in our text that the link to which is in the first slide. Number 5, in common law countries, there is a presumption of capacity for anyone over 18, and you have to have a good reason to rebut this presumption. So just because somebody has dementia, it doesn't mean you can assume that they lack decision-making capacity. Capacity is situation specific. What I mean about that is the complexity of a person's psychosocial situation. An example specifically we often refer to is in will making. There is somebody who wants to leave their one house to their husband. They perhaps may have capacity to do that. Even with severe dementia, they may not have capacity to leave a complex estate worth 20 billion with 3 marriages. These are real examples. 10 children distributed over 3 marriages, multiple share portfolios, multiple. That's a complex situation, a complex psychosocial and financial situation. Capacity is determined according to a risk threshold or hierarchy approach. One paper that I have written that I can also make available to you is the capacity needed for voluntary assisted participation in voluntary assisted dying. To me, that's the highest risk, the highest threshold, the highest hierarchy of capacity. I call that the biggest decision, and I make that hard for a person to cross that threshold. If somebody wants to decide about having a blood test, perhaps, not particularly high risk, not particularly high threshold, it might be easy to pass to. Or to appoint perhaps their husband as a power of attorney that there's no conflict with, no competing interests with anybody. That's the kind of low risk I'm talking about. Capacity is not diagnosis bound. Again, that just reinforces the notion that just because you have schizophrenia, just because you have bipolar disorder, just because you have dementia, you cannot link that to any assumptions about capacity. Merely perhaps as a trigger to rebut the presumption and consider. Capacity can't be extrapolated from cognitive performance alone. Getting a neuropsych doesn't tell you anything about performance. A neuropsych will tell the person about capacity. Getting a neuropsych will tell you about cognitive performance. You need a functional assessment. Can that person make decisions in addition to understanding their neuropsych or their cognitive screening? Can they make a decision about returning home? Do they understand the functional significance of going home? What is the nature of their disabilities? What are their needs? So you need cognitive screening, definitely, and or sometimes neuropsych, but that will not tell you whether the person has capacity. It's only the functional assessment of such, asking the specific decisions around that specific area of capacity. And finally, as per Article 12 of the Convention of the Rights of People with Disabilities, capacity is not all or nothing. Always use and consider supported decision making. So a person might have a bit of capacity and you would never revert to proxy decision-making or a robbing of autonomy as per Article 12 unless you tried at least some supported decision-making. Now, how can clinicians support the human rights of older persons in their everyday practice? I've tried to relate that as I've spoken to most of the slides, so please forgive me if I'm being repetitive. So number one, this year I was involved in developing plans for a COVID hospital. I had a human rights plan. Particularly when I saw suggestions like older people from nursing homes should be precluded from ED. I was in there with my human rights statements and insistence that we reference human rights. Highlight the importance of autonomy, free and informed consent, and respect for will and preferences when you're delivering treatment. You can refer to human rights. It's a lovely thing to do, I think, subsequently at court, if cases ever come to court, where you've actually justified why you did something on the basis of human rights and using the terminology like will and preferences and autonomy. Or conversely, protection against undue influence and abuse. Ensure in your everyday practice and amongst your colleagues, particularly those not delivering mental health treatment and those not understanding mental health treatment, ensure that principles of presumption of capacity and that the fact that capacity is not diagnosis bound is used on a daily basis. If ever you're going to use will and preferences, it's with authentic advanced care planning. Talk to the person, document what they want. If ideally before they lose capacity, but even when they have lost capacity, there is still a way of obtaining will and preferences in advanced care planning. Understand the human rights violations that underpin change behaviours in dementia, certainly in regards to unmet needs, will and preferences as articulated in Article 12 and 25. Advocate for the right to autonomy and consent regarding the segregation that's happening in residential care in the face of COVID. Push for mandatory connection. Mandatory connection is clearly as important as showering every day. Explicitly reference human rights when you're doing your medical assessments and reports. I refer to human rights in I do a lot of court reports, and I always talk about Article CRPD. I gratuitously add it, whether I'm asked about it or not. Call out ageism. As I said, join my battle. Push older people forwards, ensure their voices are heard in shaping broader macro-level healthcare policies regarding their own rights, particularly in residential care, but generally in health. And particularly in the COVID pandemic, triage for emergency care based on individualised assessment, not diagnosis or place of residence, as was tried in my own country, where a point where we were talking about just by virtue of a person coming from a nursing home, they were precluded care. And I know this happens all around the world. And if you refer to the Office of Civil Rights in Pennsylvania, that agreement, it's quite a nice case. Understand capacity. You can refer to my charity, Capacity Australia, or I will not lose an opportunity to plug my charity. It's a human rights charity, and we've developed a specialised tool for healthcare professionals across 3 countries. So regardless what background, what discipline you're from, nursing, speech pathology, psychology, social work, psychiatry, geriatrics, palliative care, that's what it was tested on. And it showed an increase in knowledge and understanding of capacity. There is the reference, and thank you for your attention, and keep safe.